Thank you, Dr. Tuhin, for the inclusion in the instruction course. So, my topic is basically providing an overview and classification of the different spectrum of ocular burns. I have no financial interest to disclose. So, basically, chemical or radiant energy injuries to the ocular surface constitute what we commonly call as ocular burns. So, as sir has rightly mentioned, it is the true ocular emergency. It can cause extensive damage and significant ocular morbidity to the ocular surface, leading to blindness in the long term. For developed countries, we have the statistics which say around 1.25% to 4.4% of the total burden of blindness. It's more commonly seen in men, either in their workplace or homes. Sometimes it can be a result of assault or vitriolage, which has some medical legal implications as well. So proper history taking will help us determine what is the mode of injury, whether it is deliberate or accidental. So if you see the statistics from the developed world, most of the common implicated agents are the household cleaning agents, either the bathroom cleaning acids or the strong alkalis. So they constituted around 29% of the total cause of ocular burns, and in males it was around 57%. The next common was more personal care products and automotive chemicals. Then the percentage goes on reducing for the other chemicals which you come across in day-to-day life. So if you see in the details of the household cleaning agents, the most common was bleach, so which is a very strong alkali. There are certain all-purpose cleaners, disinfectants, laundry detergents which make up around 15 to 20% each. In personal care products, hair products like dyes, coloring dyes were most commonly implicated. In the other automotive group, the splash of battery acid, which is basically strong sulfuric acid, that was most commonly implicated in the causative agents. So if you see this graph in which the percentage of the rate of injuries, ocular injuries by certain burns, caustic alkalis, acids, was plotted with the age of the patient. So you see two peaks. So one peak is in the early childhood, around 0 to 5 years of age, in which the children are caught playing with certain offensive agents. And then there is a decline in these adolescent years. Again, there is a peak in the younger outgrowing group, mostly in the males, maybe around 18 to 30 years of age, who are engaged in. As the age increases and the person becomes more confined indoors, doesn't lead active life, the rate of ocular burns reduces. So again, this study is from some Indian data way back in 1993, in which again commonly the alkalis were around 36% of the causative agents. Acids were more commonly seen, 48%. Certain miscellaneous chemicals in the laboratory around 14%. And as expected, factory workers, laboratory workers were more commonly exposed to these offending agents. So this study from RP Center, in which they have studied the clinical profile of ocular injuries in the pediatric age group. So the most common offending agent was bursting of tuna packets, which I will come to later, in which certain measures have been taken by the government. So if you see the classification of the ocular burns, Balen introduced the first treatment and the classification of the eye way back in 1964. So Roper and Hall modified this Balen's classification, and it was quite in use for so many decades until we came to the Dua's classification, which is currently the most widely accepted and used classification in practical day-to-day clinics. So if you see the Roper-Hall classification, which is the modified Balen classification, there are 4 grades, and you have the damage to the cornea and you have the conjunctival or the limbus involvement. As the grades increase, the prognosis worsen. So in grade 1, it is just mild epithelial damage and the limbus and conjunctiva are intact. As you move to grade 3 and 4, so basically the entire cornea is damaged and more than 6 clock hours of the limbus or the conjunctiva are also having ischemia. So these are some of the, basically this is not the Roper-Hall, this is the 5-star classification which came between Roper-Hall and Dua, in which these photographic images were used as a reference to use in the clinic, and these images were compared to the patient's eye, and then the grading was done, like normal, mild, moderate to severe. So if you see the very severe, which would maybe about grade 6 of Dua, so complete blanching, whitening of the cornea and total scleral ischemia. But this is not easily reproducible. It is quite subjective. What I may say mild, somebody may say normal. So this was not very much in use. Then we came to the most current classification, that is the DUA system, in which we have 6 grades. The prognosis obviously worsens from grade 1 to 6, and you have clock hours of limbus involvement, the percentage of involvement, and the analog scale. So basically, as you move in severity, maybe the photo I showed earlier. So grade 6 is very poor, in which the total limbus, 12 clock hours are involved, and the conjunctival involvement is also 100%. So you have these images from the original article in which the different grades, and so this would be a grade 3 in which the conjunctival limbus is involved with a persistent epithelial defect. So fluorescein stain is extremely important in identifying the extent of damage. What may appear clear on the slit lamp may actually be a total epithelial defect which may get missed if you don't use fluorescein stain. So you have different images to go through, and this article was from BGO in which they compared the value of Roper Hall and DUA classification system, basically a head-to-head study between the two systems. So basically Roper Hall, since it stops at grade 4 and DUA stops at grade 6, so basically the DUA classification has a superior prognostication value because you have more variables to play with. So this another classification came out in 2020, which is not in practical use, but then they have given grade 0, 1, 2, 3, and opacification of the corneal surface, the vascularization of the surface, and the degree of symblepharon formation were used to classify the degree and the severity of the ocular injury. But as I said, it is not in common use, it's just one more classification. So we all know that limbal ischemia, the worse the ischemia, it is giving rise to worse prognosis. But this study, which was carried out in IGO in 2019, in which a series of photographs were presented to both cornea specialists, general specialists, and fellows, in which they were asked to just look at the image without looking at the patient themselves, what grade they feel this image represented on the DUA scale. So as they found out that there was a wide disagreement between the specialist and the general ophthalmologist, because the photography is highly subjective. So what I may feel this is severe ischemia, somebody may say this is grade 2 or grade 3. So we still don't have a very subjective classification system which covers all the aspects, especially the scleral part of it. So now we move on to the new kid on the block, is basically the application of OCTA, that is OCT angiography, to the anterior segment. Our vitreoretinal colleagues are very familiar with this diagnostic modality. For us, it is quite new. So this can be used to prognostic the injury in the acute stage and then decide whether you need more invasive procedures like a AMT or tenonplasty to establish vascularity on the surface. So this article has shown that ASOCT angiography, it's an objective, non-contact and a rapid assessment of limbal vasculature. However, we don't have very great indices to assess this. So that extent, Dr. Science Group has come out with this article providing a review of the role of OCTA in, you just see two different images on the top panel and the bottom panel. So on the left is the OCTA image of the 4 quadrants of the limbus. And you see this, the patient has presented on day 1 with total epithelial defect on the cornea. As the days have progressed to day 7, day 14 and day 28, by the 28th day, everything has healed nicely. The limbal vasculature is also not much disturbed. The inferior panel shows some disturbance because of the disturbance in the conjunctival cornea, the conjunctival epithelial defect. But you see the bottom part in which the vessels are hardly seen, and as the days have progressed, the epithelial defect has just healed only slightly, leading to what we call as PED, or a persistent epithelial defect, by day 28. So the management of top panel and bottom panel is totally different. In the bottom one, you would be more aggressive with your initial management. Again, with the similarly on diffuse illumination, on fluorescein stain and OCT imaging. So you have day 1 images going up to 6th month. So you see in this panel and this panel, there is a persistent epithelial defect by 6 weeks, and it has led to a local limbal stem cell failure, and a pseudopterygium has come into the picture and the surface has healed. So the vasculature is quite intact, just that there is focal LSCD. So definitely this article has shown that clinical examination alone is insufficient to assess the presence and extent of ischemia. We need something which is more objective and gives us the images which is rapid and non-contact. Now we have more indices to assess the parameters on Octa. So now we can serially monitor these patients to differentiate what is actually ischemia and what is vasospasm. Vasospasm can easily resolve with conservative management, but if it is true ischemia, you need more aggressive management right from day one. So this, as talking about tuna packets, so this advisory has come in collaboration with the government of India, in which say no to tuna packets. Please discourage children from buying these on behalf of their elders, because they play this, throw it in the air, the packet just bursts and causes devastating injuries. So the take clinic message is, it's a true ocular emergency. It can cause significant morbidity and blindness. You need more public awareness. You need a better classification system, because the scleral ischemia part is not very clear in the current classification. And you need more standardization by Octa. Thank you so much.
Excellent presentation, Aditya. So, take-home message from your presentation for those who do not have access to OCT-based angiography would be that what Dr. Dua has done, he has mainly differentiated, he has discouraged the use of term ischemia. So, right away we cannot say that it is ischemia. You just have to stain the limbus. If there is limbal staining, you just say that it is involvement. Assess the patient daily whether the staining is decreasing at the limbus and the epithelium is healing. If it is healing, then we can say that it was just an involvement and not ischemia. It was reversible, or rather vasospasm. Yes. And we can get away with that case. If on a daily basis, if it is not healing, then probably it is an ischemia. So probably even if we don't have the OCT angio, we can just look at the picture and assess daily and just label it as ischemia and involvement later on.